Ya, Assalamualaikum warahmatullahi wabarakatuh. My name is Brahmanta Arsy, and my name is 30102100005. I'm from EMAP Group 2, and this is my uh, form uh, about my RCT journal uh, that I found it in PubMed website, and I will present it for the test. So it's from WHS Public Access. The title is The Informations Without Implementations, a practical example for developing a best practice education control group. So from the abstract, this paper considers methodology from developing an educations-only control group and propose a simple approach to designing rigorous and well-accepted control groups. This approach is demonstrated in a large randomized trial. Lifestyle trials like the compared three group interventions. The first group is cognitive behavioral treatment, or CBT, for osteoarthritis pain. The second group is CBT for osteoarthritis pain and insomnia. And this third group is education only control, or EOC. EOC emulated the interventions excluding hypothesized treatment in components and controlling for non-specific treatment effects. Results showed this approach resulted in a control group that was highly credible and acceptable to patients. This approach can be an effective and practical guide for developing high-quality control groups and trials of behavioral interventions. The introductions. Well-designed control groups are essential for scientific evaluations of behavioral interventions, such as cognitive behavioral therapy. External factors which may be mistaken for specific treatment effects of behavioral interventions include attention social support, altered expectations, and changes in patient stature not due to the interventions such as regression to the mean of natural history. It's from Borkovic and Zibara, 2005. There is an extensive literature on profile control groups and on specific effects of participations yielding clinically meaningful benefits. In situations where non-specific effects might contribute to the positive impact of behavioral interventions, the design features of the control group are essential for obtaining accurate estimates of the efficacy of the treatment interventions being evaluated. Uh, this paper describes how one research study used control group recommendations to guide the design of comparison conditions in a large randomized trial for insomnia and chronic pain among older persons with osteoarthritis. To summarize the process of designing rigorous and participant-accepted control groups, we used a simple phrase, informations without implementations, which means providing educational content and non-specific support to control subjects that corresponds to what is offered in the active interventionist arms, but excluding the behavioral treatment components that we are a priori hypothesized were active ingredients of the interventions, and that study participants were asked to learn and practice. These papers describe how a control group interventions designing using this approach achieved favorable patient expectancies and high levels of patient participation and retention. In addition, we discussed factors that could contribute to more widespread use of effective controls in clinical trials of behavioral interventions in the future. And then the methods. The first one is design descriptions. Lifestyle was a double-blind controlled cluster randomized trial with longitudinal assessment of pain, sleep, mood, and function. Detail of study design, recruitment, and primary pain and sleep outcomes have been published, whereas participants received one of three groups interventions. The first one is cognitive behavioral treatment for osteoarthritis pain only, or CPT strip P, and the second uh, uh, group intervention is cognitive behavioral treatment for osteoarthritis pain and insomnia, or we can call it CBT strip PI. And the third uh, group interventions is education only control, or we can call it EOC. Each group consisted of 6 weekly 90-minute classes conducted by the same two interventionists. During the recruitment process, potential participants were told the study was comparing three treatments that dealt with pain, sleep, and activity. One program focused on lifestyles changes, another on relaxations and positive thinking, and a third that combined these approaches. Participants were not informed there was a control group. Participants were not informed there was a control group. At the first session, participants were told that they were assigned to one of three treatment conditions that teach participants strategies to help manage osteoarthritis and associated difficulties such as pain and sleep. And the purpose of the study was to determine which group might be the most effective. Participants were not told how their group differed from any other. Participants received a $50 incentive payment after completing the baseline assessment and attending the first group session. Participants in all groups also received a reminder telephone call from an interventionist 1 or 2 days prior to the first class only, and call for the first inspected missed call. And then the information's development, identifying the active ingredients. The two treatments, CBD strip P and CBD strip PI, were designed to test interventions based on biobehavioral model of chronic pain dysfunction. Prior to development, all the treatment manuals, the pain and insomnia treatment literatures were reviewed, and experts in the field were consulted to assist in protocol development. All three groups received copies of the Arthritis Help Book and Heart Compatible Social or Environmental Group Experience. Content in CBDP and CBD strip PI arms was closely matched for those active ingredients hypothesized based on the treatment literature either to directly produce reductions in pain, relaxation, instruction, cognitive restructuring, or that are recognized active components in many behavioral interventions. The CBDPI arm additionally included components designed to impact homeostatic and circadian sleep processes. The active components of the CBD strip P and CBD strip PI interventions are involved participants practice both in and outside of the group sessions implementations. These active components were broadly categorized into three domain areas: altering activity patterns or attention different techniques, changing automatic thoughts, and maintenance. Since the basic pain and sleep education offered in all three treatment arms, an additional educational material offered in the EOC to stimulate group discussions did not require any additional participants. Practice education was not in itself conceptualized as an active treatment component. In combinations, these design elements allowed for control of non-specific treatment effects, including therapist attention, group social support, treatment duration, basic pain and sleep, knowledge acquisition, and therapist quality. And then the achieving balance on non-specific effects. In designing the study, treatment, fidelity, procedure recommended by Lichten's to standard to standardize treatment dose were followed. All groups met for the same number of sessions or the same time interval, and all sessions were approximately 90 minutes in durations. All sessions were conducted with both interventionists present to minimize therapist bias. Interventionists were told that the EOC group was an educational comparison condition that included information in a support group format that is widely used and accepted for management of pain and insomnia symptoms in the real-world clinical care, but that needed testing in a randomized trial. And then we got the evaluating perceived treatment credibility. Participation rates. We examined the mean, median, and interquartile range from the participations within each arm and report the results of non-parametric cross-call-Wallace test for between group differences and participation rates. We also examined retention rates between each arm at the second month post-treatment, 9-month, and 18-month follow-up assessment. Participant treatment perceptions ratings. We asked trial participants to rate the credibility, acceptability, and perceived effectiveness of their group interventions. Rated items were based on prior work. That be the first is, does this treatment and its rationale make sense to you? And then the second, how acceptable do you consider this treatment? And the third is how suitable is the treatment for improving your quality of life despite having osteoarthritis. The fourth is how effective do you expect this treatment to be? And the fifth, how well do you think you will be able to adhere to this treatment program? Ratings were completed at 2 time points. The end of treatment session first. And again, as part of the second month post-treatment assessment, all items were rated on a scale from 1 to 7, or low to high. We examined the percentage of patients indicating a high positive receptions rating, 5 plus out of 7, across the 3 treatment arms, and report the results of chi-square test between group difference. So about the results, the trial sample, the lifestyle trial included 367 participants, means age 73.1 years and 78.5% female, as assigned to the 3 treatment arms. The EOC have 123, and then the CBT strip P have 122, and CBT strip PI have 122. Participants did not differ significantly across treatment arms by age, gender, ethnicity, education, or by primary or secondary outcomes measures at baseline. There were 39 groups assigned across the 3 arms, with 14 groups assigned to EOC, 12 groups assigned to CBT strip B, and the 13 groups assigned to CBT strip BI. There was an average of 9.4 participants per group. The largest group had 12 participants, and the smallest had 5 participants. And then the participant session attendance. The mean number of sessions attended out of 6 was high for all 3 treatment arms. Given the distribution of the session attendance data, medium and interquartile ranges, or IQR, for each arm were compared rather than mean values. The chi-square of the cross-call-Wallace test for between group difference was significant. For the participants' perception, Participants' pre and post interventions perception of the credibility, acceptability, and perceived effectiveness of their group interventions and are displayed in Table 2 at the end of the first group session. Participants were asked to rate what they thought of the overall program after it was explained to them. Overall, the large majority of participants in all three groups gave the high five ratings in all items. The G-squares analyzed showed significant between group difference on two items. The first item is how suitable in this treatment for improving your quality of life despite having osteoarthritis, and a very similar ratings for the EOC and CBT-3PI. And the second is how well do you think you will be able to adhere to this treatment program. At post-treatment assessment rating declined somewhat, but generally remained moderate to high for all groups. G-square between group analyzed showed significant differences for three items. The first one is that this treatment and its rationally make sense to you. How suitable was this treatment? The second one is how suitable was the treatment for improving your quality of life despite having osteoarthritis? And the third one is how effective do you expect this treatment to be? And then we continue to the discussion. In the lifestyle study, information without implementations was used to guide the successful design and executions of all control arms that was observed to have favorable perceptions of face validity, group attendance, and long-term study retentions. When compared to two active behavioral interventions, we observed some differences in attendance and perceptions between the randomization's arms, but these differences are not large, suggesting participants in the control group did not reject the idea that the control arm was a viable treatment option, which suggests that the fast information without implementation offers a simple tool for remembering and implementing steps in the design of incredible and acceptable control groups for behavioral interventions. The essence of this tool involves identifying active ingredient of treatment interventions and developing a control arm that includes the non-specific effects and education in all interventions domains. But without including any hypothesized active ingredients, participants are asked to learn and practice the implementations. Drawing on experience from the lifestyle randomized control trial, we found that a control arm developed following this approach was acceptable and credible to participants, control arm members. Participants in the intervention sessions was high and all on par with the active treatment arms. In fact, when comparing attendance data for all three groups, median and interquartile ranges for the EOC and CBT-3PI groups were similar and had higher attendance observed in the CBT-3P group. We observed differences between the treatment group for the treatment suitability and projected ability to adhere the treatment recommendations, with the greatest number of participants in CBT-3P giving high ratings to high 5, followed by EOC and CBT-3PI. At post-interventions assessment, there were no statistically significant or meaningful differences between groups on the questions regarding treatment acceptance or belief. There was also a statistically significant between group difference on the questions regarding perceptions of effectiveness, but the EOC group having lowest number of high ratings at follow-up. Between group difference of early participants' perceptions regarding treatment rationally, acceptability of effectiveness were not clinically meaningful and not statistically significant, although perceptions of the participants assigned to the control arm regarding effectiveness decreased marginally over time. A majority of control arm participants continued to rate it highly. This decrease in perceived effectiveness was not unexpected since many participants in the control arm did not experience improvement in their sleep and pain symptoms. Nevertheless, study retentions of EOC participants remained high throughout the 18 months follow-up, indicating sustained enthusiasm for study participation is comparable to that in the other active interventions arms. We found this an encouraging finding because dropout rates are often the highest amongst control groups. It should also be noted that there may be circumstances in which an treatment as usual control arm is appropriate. Certainly, this design offers important financial advantage. Researchers may want to consider a treatment as usual control arm when there is a standard practice already in regular use. A treatment arm may be useful in demonstrating interventions differences from an education-only control group and may be particularly useful when there is a high level of uncertainty regarding possible active treatment components which could create the risk of a control group with treatment effects. However, researchers utilizing this type of control need to be aware that particularly in behavioral research, such approach just typically fail to control for non-specific effects of an intervention's actual active treatment effect size may be smaller than they appear when only tested against a no treatment comparison. The use of the same intervention as in the current study to run all groups is both a strength and a weakness. Utilizing the same therapist can reduce therapist effects and is more cost efficient. However, it also makes it more difficult to maintain therapist allegiance to the control method requires continual monitoring, monitoring to ensure that there is no spillage of active treatment components over into control group session. Despite our best efforts, we cannot be certain that therapists didn't know the EOC group was an active control group and how that may be impacted how they ran groups. Given that this study did not employ a fidelity measure regarding this level of potential therapies, bias were limited to the implementation's fidelity checklist, which did in fact measure how well they adhered to treatment protocol and check for possible drift. However, there may be more subtle forms of therapist bias in the areas we did not assess. This is a common dilemma for trial development, deciding if the same therapist for the different arms will help reduce therapist bias or if the same therapist will reduce therapist effect. This must be considered when developing the trial subsequent training and analysis plan. The lack of independent or blended fidelity ratings on the random subset of taped sessions is also a potential limitation of the study, and future investigators should consider adding this evaluation as component if ratings are being used by supervisors as part of ongoing clinical monitoring. Lastly, is an any study sample itself must be considered. We don't know if there is something unique about our study populations such as older age, comorbid osteoarthritis, pain, and insomnia, or other sample characteristics which may have influenced the acceptability of the provided education only control group. This may be addressed in the future. If other studies decide to adopt the suggested control group development methodology with different populations, although conceptual guidelines for developing effective control groups in behavioral studies have been described. A number of factors likely contribute to this failure. The hypothesized mediating variables through which treatment influences outcomes are not always as well understood or defined as they are for sleep and pain, making it difficult to develop a control group that deliberately removes that act these active ingredients while retaining non-specific treatment elements. Rigorous behavioral control groups are also more expensive to implement than waitlist care as usual or booklet education conditions. Although this is not a small consideration in an era of shrinking healthcare and research budgets, the design of the control group is nevertheless essential to the ability of a randomized trial to estimate specific interventions effects and to differentiate them from non-specific effects of attentions and favorable expectations of participants. Because the challenge and expense involved in designing a good control group simply needs to be faced head on to the extent possible. In conclusion, the lifestyle trial demonstrates the successful development and implementations of a viable education-only control conditions for a behavioral trial examining chronic pain and insomnia that was both highly incredible and acceptable to patients. These comparison conditions could serve as a possible control for the other trials in these topics areas, and certainly there's a history of viable control groups. These areas, but more importantly, this concept for information without implementations may serve as a practical model for controlled development in other areas. Yep, this is my presentations from the RCT journal. Thank you for your attentions. Uh, I'm sorry if I make or or I said any uh, not good uh, word or bad word. Uh, Thank you very much. And wassalamualaikum warahmatullahi wabarakatuh.